Welcome to RUMC Connections. So welcome to RUMC Connections, the podcast where we bring you behind the scenes of Richmond University Medical Center, the stories, the science, and the people driving care in Staten Island and beyond. My name is Meredith Gaskins, and I'm joined today by a special guest who leads some of the most intense high-stakes operations in the hospital, the Medical Intensive Care Unit. Our guest is Dr. Mbeng Nfonoyim, a critical care physician, educator, hospital leader, and someone whose journey is as inspiring as the work he leads. Dr. Nfonoyim is the Vice Chair of the Department of Medicine, Chief of Critical Care, and Program Director of the Internal Medicine Residency at Richmond University Medical Center. Today, we will pull back the curtain on what happens inside the ICU, how teams handle life or death decisions, and the many lessons learned from the crisis, from ordinary to extraordinary. We'll also explore Dr. Nfonoyim's personal journey, which is as inspiring as you can imagine. So from a seminary-style boarding school in Cameroon to leading one of New York's busiest ICUs, and what it really takes to lead a team where every second truly counts, right? So welcome. Thank you so much for joining me today.
Thank you very much, Meredith.
Of course. So welcome to the show. Let's start at the beginning. So you grew up in Cameroon, attending a Catholic boarding school that initially prepared you for priesthood, but your life took a different path. So what was that experience like, and what would you say helped shape your decision to pursue medicine instead of ministry?
I think it was a wonderful journey. At this time, I don't have any regrets not being a priest. I feel being a physician is just like being like a priest. I've always looked at both as servants of the same secret purpose. Both bring healing and hope to those who are suffering.
Very nice. Okay.
One heals through faith and the other through science. Both are called upon to restore health, take away despair, and make people feel comfortable. As a physician, I encounter people in their most vulnerable state, frightened, in pain, uncertain of what lies ahead of them. In those moments, I'm reminded that healing goes beyond prescriptions or procedures. I'm reminded that healing goes beyond that, but at the same time, you have to think of the priest who goes with compassion and understanding, taking care of the body, taking care of the soul, and we're taking care of the body.
I like that. That's a very good comparison. Very true. Okay. So was there a moment or experience that made you maybe realize that your calling to heal was through medicine rather than the church?
I think it was just a coincidence. It just so happened that I spent more time away from school near a hospital and doctors and nurses than when I did while I was in school. I had a priest in school, I had reverend brothers, but when I went home, most of the people around me were in the healthcare profession.
Okay. Yeah. Was anybody in your family in the hospital?
No, nobody. My dad was in the hospital a couple of times, and I had to stay in the hospital with him. That really changed my life.
Wow. Yeah. Kind of opened your eyes to the medical field and what was out there.
Yeah, we lived right next to the hospital, and we did.
So I understand your childhood home was right next to the hospital, like you said. So watching those, doctors and patients every day kind of played a role in inspiring you then towards medicine?
It definitely did.
Mm-hmm. You eventually did earn your degree at Santiago University of Technology and completed intensive care training at Mount Sinai. What was it like adapting to the U.S. healthcare system as an international physician?
It was... Right now, I would say it was easy, but in retrospect, while there was no knowledge gap, there was a system gap. You come here with all the knowledge that you have, and you start learning very, very fast that it's not just taking care of patients, but the documentation. You have metrics that you have to follow. You have to write your notes in a particular way. So those differences were there.
Okay.
But all in all, I'm very, very happy I was able to make it here and adapt.
Were there any mentors or maybe like early experiences in your training that helped shape, how you lead today?
Some great women and great men that were on my path when I through medical school to fellowship, and I'm really very happy. They taught me a lot of things, and I'm saying these nurses, respiratory therapists, I learned from them how to be humble, how to communicate, how to how to listen, and how to work in a team.
Absolutely. Yeah. It's a lot of teamwork that goes into the ICU, I'm sure.
Yeah.
Okay. So now you are a leader at RUMC. What values would you say from your upbringing in Cameroon do you still carry with you into your work in the ICU?
I think the most important one is humility and resilience. Humility, which I always tell every young person I meet, especially those my residents, while it might sound as if it means you're timid or you're shy, it simply means you care about yourself but not any less about anybody else. So I teach that, and if you care about yourself and care about everybody like you take care of them, you take care of your patients, you speak very well to the relatives, and you speak very well and respectfully to everybody you work in the hospital with, whether it's the director, the CEO, or the person just mopping the floor.
Yeah. Treating everybody the same, right? And I think that's something in my almost 4 years now at RUMC that like I've really, grown to appreciate is that it's like a family. It's that everybody really truly looks out for each other, and I think you could see that with the care that they exhibit towards patients too.
I would agree with you, because it's like the RUMC is like a family.
Yeah.
You look around and you realize I've been there for, I don't want to tell you how many years, so quite a few years. And if you look at my faculty, most of them trained and they stayed there. It's just a warm environment, a very family-oriented environment. Yeah.
Absolutely. Okay. So for many people, the ICU is a mysterious place. It's full of technology, alarms, urgency. It's a scary place for a lot of people. So is there a typical day inside the ICU, would you say? Or is every day different?
No, there are different days, but generally, I mean, like you said, for many people, the ICU feels like a very different world.
Yeah.
As you said, it's a place where you have a lot of technology, alarms, urgencies. However, all this technology, behind all that technology is human beings working day by day to take care of sick people. On a typical day, you start with your rounds in the morning. By 6 o'clock, we're there. The physicians, my team is there at 6 o'clock. By latest 6 o'clock, we do first rounds, just walk from bedside to bedside. Somebody tells you how the patients were overnight, how did they sleep, who needed to have oxygen change, who needed to get blood pressure medication, whose family needed to be called. And after that, the residents who were on nights get to leave.
Okay.
And the nurses do the same. At 7 o'clock, they sign off to one another. That's basically what happens at that time. Then soon after that, you have rounds. Those are the day staff, the day residents, where you get to talk more detail about the patients, the plan for that day, look at their labs, their images to make a plan, and also assess and see who is going to be more challenging for that day. When I say challenging, as far as their condition is concerned, than the other. And after that, we go around, take care of due procedures, attend to little things that come on. You know how things change in the ICU, and we then go to do what we call teaching rounds. Where this time you have to talk to the residents, teach them about the physiology of the diseases that they are seeing, the pathophysiology, teach them how to be good physicians, basically, how to work in a team, what to look for, how to examine patients. So that's how the day goes, and finally in the afternoon you kind of say, all right, my day's come to an end, the new crew is in. You give them a report of how your hours were, so they can they know they have a way to start their day, and they get to know what to watch out for, and who to pay more attention to than the other.
Okay.
That's a typical day.
How do you balance being a physician at the bedside with your administrative duties, leading the division?
It's intentional. You have to be intentional because both of them are demanding.
Yeah.
You have to be intentional and divide your time, just making sure that one doesn't interfere with the other, especially the clinical time. I don't mess with it. I don't sacrifice that. So in the morning, I spend about 30 minutes in the office, then go to the unit where I stay for maybe 4 or 5 hours, taking care of patients. I do respond to administrative things if there are emergencies. Otherwise, I don't let the administrative responsibilities affect the care that I give to the patients. Yeah.
Got it. Sure, patients, always come first. Okay. So you've said that in the ICU, we don't have the luxury of time. What does that mean in practice when a patient's life can change in any minute?
Yes, you're right. When I say in the intensive care we do not have the luxury of time, I'm speaking about the reality that occurs there minute by minute. You can have a critically ill patient who is feeling, appears to be doing well right now. The next minute they are decompensating and you need to do something. A lot of time, illnesses behave unpredictably, and you just have a razor-thin margin in time to be able to prevent something from going wrong.
Oh, yeah.
Yeah. A patient's blood pressure, respirations, heart rate can be stable now, and the next 2 to 3 minutes, you have an issue. So what that means is that we must coordinate our care, pay close attention to the patients, and act, how can I put it? When things go wrong, you don't have the luxury of time. You have to think very fast, make decisions very, very fast.
Yeah.
And that is usually backed by your experience, and that's why it's always good to have a senior person around in those times. So that's why I said is you don't really have the luxury of time. Yeah, because if you don't act, as a matter of fact, that's one of the things that got me into critical care. Somebody is not doing well, you go and you make your intervention and you see results immediately.
Absolutely.
The flip side of that is if you're not available and you don't make those decisions, the outcome is going to be bad. So it's a big responsibility which I feel privileged to have. Yeah.
Wonderful.
Yeah.
And what would you say are some of the most common, cases that you see in the ICU?
Most common cases, all depends. If I look at it systematically, the first is like respiratory failure, where your patients have pneumonia, they have asthma, they have pulmonary embolism, maybe they have COPD.
Okay.
And the other group is people who have infections and they're in shock. You need to take care of them. And obviously, there are people who have cardiac issues. They have heart failure. They're doing well, but at some point they just decompensate, and you really need to take care of that as well. You have people with kidney failure that you need to put on dialysis.
Yeah.
You need, or if not, even if you don't have to put them on dialysis, their electrolytes are abnormal. You need to take care of that. Otherwise, they develop arrhythmias and don't make it. There are people with strokes. A lot of things.
That's a lot.
People with strokes, people who come in with intoxications, either opiates.
Yeah.
People withdrawing from alcohol. You just have to. When I say people withdrawing from alcohol, I always emphasize that a lot of people do not realize that the likelihood of dying, believe me or not, from having delirium tremens, which is withdrawing from alcohol, is almost as high as dying from a heart attack.
Wow.
Yeah. So those are some of the emergencies we really have to deal with. Yeah.
Okay. So, that's quite a lot of different conditions. So how do you coordinate care across so many specialties, from respiratory therapy and nephrology, nursing, pharma? It's such a high-pressure environment, too, to have so many different things going on.
That's an interesting question. Coordinating care in the ICU feels like conducting an orchestra during a storm.
Yeah.
Complex and fast moving.
Oof.
To make it work, however, it has to be structured.
Okay.
You maintain a good relationship with your consultants and with everybody else in the team.
Yeah.
You have to make them realize that they add value. and that the goal of getting the patient good care is not a singular goal. It's a goal for a team, and they belong to that team. Yeah, so that's just the best way to put it.
So I imagine you work with a lot of different teams.
I work with a lot of different teams, a lot of different specialties, and I'm we're very lucky. Everybody's very responsive at RUMC.
Okay, great. Yeah, very important. Yeah. Okay. And so the MICU at RUMC recently expanded from 10 to 14 state-of-the-art rooms with new family accommodations built right into the design, which is truly beautiful. So how would you say that that's transformed the patient and the family experience?
It really has done a lot. That's one thing that we did not have. Families add a lot to the care of patients. In fact, the Society of Critical Care Medicine of America basically said, we have this bundle, an A, B, C, D, E, F bundle, which if you follow, your patients do better. And F stands for family.
Okay.
Yeah. So the family engagement has been shown to improve satisfaction, communication, help with post-traumatic stress syndrome, which occurs in a lot of patients who go through the ICU. Yeah. And some of the family members themselves seeing their loved ones in the ICU, they can have that. But just having family around helps with that. And I said, in the ABCD bundle, when you talk of family, you're talking of, okay, the same thing that they're telling you to do in the morning for everybody, try to get them off the ventilator. They're telling you, you have to look at this sedation or this analgesia. So it's really very important.
Yeah, absolutely.
Yeah, so family, can't take family away from the care.
Involved in what's going on and then being there for the patient themselves. Absolutely, I can imagine.
We've been encouraged to let them to partake in the care if they want to.
Yeah, I'm
as
sure.
As long as it doesn't interfere.
Yeah, I think it would help improve outcomes for patients if they have their family close by.
Close by, they're thirsty, and if they're not, they don't have any reason why they can't drink. Let the family member assist with that. It might not seem a lot to us, but it means a lot to the patient and the family, the family member. Yeah.
Of course. Okay. So sometimes patients, stay in the ICU for weeks or even months. I mean, how does your team, prevent compassion fatigue or burnout among staff during, these long emotionally charged cases?
Yeah, you're right. The first thing is to let the staff know how to recognize this.
Okay.
When they start losing empathy, when they start feeling detached from the patient or their family, or they start feeling they're losing the meaning of what they do.
Yeah.
They should that is a sign that they're getting to that point. And the best thing to do is if they can recognize it, then you help them provide a means where they can debrief, especially if it's a stressful situation, of course. You bring them over and say, I know how you feel. We all go through this. Let them talk it out, talk it over.
Yeah.
And there are occasions where you might even have to do some reassignments in the assignment if it's possible, just so they can decompress a little bit. It's natural.
Of course,
so
it's a very intense.
You have to accept it and work with the staff on that, and that includes me too.
How do you decompress?
How do I decompress? I basically tell myself, while I'm here for this patient.
Yeah.
When I leave and go back to the office, it's a little bit different.
Yeah.
Yeah. So I don't get that as much as say my nurses who are there for 12 straight hours.
Yeah.
So I go in and out.
Okay, so that helps, I'm sure, a little
helps,
bit.
Yeah. That generally doesn't occur that much, but they're challenging situations.
Yeah.
Where you just can't take it anymore because you think you're not really doing, you're not offering anything because things are not going the way you expected them. Yeah.
Of course, yeah. Sometimes there's only so much you could do while you wait. Yeah. Okay. So you've said that comfort can be just as important as medication. How do you bring that philosophy into such a clinical environment?
Comfort in the ICU is healing. It's the healing that comes without technology and expertise. It's very important in the critical care arena. And believe it or not, caring, comfort and compassion, it can be something as simple as having a nurse position a patient well so they can breathe.
Okay.
They can breathe well. It's something as simple as speaking to a family member at the bedside, holding their hand. All those things really do.
They make
they make a big difference. You're comforting them. You're not giving them any medication, but you just let them know you are there with them. Yeah, you feel what they're going through.
Yeah,
and the patients. Yeah.
In all of your years now in the ICU, do you have like any most memorable, patient stories that stand out to you, or?
Yes, I do quite a few, but I tell you, one is a young person who came in, and we were able to get this young individual managed on the ventilator for a while, and we just couldn't do it anymore. We sent him out to call Mount Sinai. They came to the unit and cannulated him, took him out, and let me see, about a month later on, he came to the ICU.
Again?
Alive.
Oh.
To visit.
Wow.
And that was, we didn't think he was going to make it, but he did, and the family has been coming to the hospital every Thanksgiving. As a matter of fact.
Should be coming soon.
They'll be coming soon, yeah.
Wow.
They've been coming every Thanksgiving, and the other ones that I remember during the COVID period. Good is, I remember a lady who came in, almost died on the ventilator.
Yeah.
Were able to pull her through. She was able to have the baby.
Oh, she was pregnant.
She was pregnant. She was able to have the baby, and that's, I still think about it up till today.
Wow.
I still think about it up to today.
Yeah. Well, you must have been inundated in there during COVID with the amount of people, on the ventilators and. Yeah.
No, we definitely were. We definitely were, like most other hospitals in New York, but
yeah,
we had to do what needed to be done.
Of course.
It was very, very challenging, but
yeah. Well, the whole hospital kind of became an ICU during that period.
The whole hospital was one ICU.
Yeah.
The strange thing is, during that time, you didn't have people coming in with myocardial infarctions.
Yeah.
You didn't have people coming in strokes for some reason.
Isn't it odd?
Yeah.
So many people have said that. Yeah. Yet it's like all these other, scenarios just kind of stopped, and it was just COVID related.
COVID. Yeah, it was COVID
Very
related.
interesting. I wonder, why that stuff kind of fell by the wayside.
I don't know why.
Yeah.
That's what happened. Yeah.
A very interesting time period for sure.
Yeah.
Wow. How would you say that palliative care maybe works in tandem with critical care, and how do you help families make, difficult decisions when some of these outcomes may be uncertain?
Critical care and palliative care sometimes are viewed as opposite ends of the spectrum. They, however, are very essential in the ICU.
Okay.
Critical care keeps your patients alive, and palliative care ensures that no matter the outcome, alive or not, people are cared for with dignity, with a focus on their values. So palliative care doesn't mean the patient is going to die, because that's what a lot of people think, but it's just that palliative care specialists are more trained better in how to communicate, how to incorporate the patient's values into the care that the patient is receiving.
Okay.
So we work really hand in hand. Yeah.
What would you say maybe changed permanently in critical care because of COVID, maybe in how we prepare or communicate or even use technology?
Plenty has changed.
Yeah.
Yeah. As far as clinical care is concerned,
Yeah.
The use of high flow oxygen, the use of non-invasive ways of ventilating patients, and delaying a little bit on putting patients on the ventilator. We do that more now than we did before.
Okay.
We do that more now than we did before. And then the other thing is, from an operational point of view, a lot of institutions have built in surge capacity. Like in our institution, the ICU is built now in such a way that if there was anything were to happen, we can double the size of the ICU.
Yes.
And a lot of institutions have that as well.
That capability.
That
Well, I think that's very
capability,
important, of course. Just, given you never know if there'll be another, hopefully not, pandemic or something like that, then to have that ability to expand. Absolutely. So I know that RUMC is invested in telemedicine and ICU remote monitoring even. How are those tools reshaping patient care or helping during, these type of surge events?
No, it helps in lots of ways. One, but before I even say that, let's move away from RUMC. In some places, the ICUs are just telemedicine covered. There's no physician; everything is telemedicine.
Okay.
And a lot of that knowledge was gained from COVID, the COVID time. So how is that helping us? We're able to get in touch with consultants for emergencies that, like, somebody has a stroke, the consultant can communicate through telemedicine while they are on their way in, that things can get started.
And then how do you prepare, residents or staff for that kind of crisis, medically or professionally?
I think the best way, what I would say, what we did to prepare them is, it was a chaotic time.
Yeah.
And what you need to do is remember clarity. Everybody is scared. Everybody is confused. Just clarity is the most important thing. Whenever something changes, let everybody know. Be very truthful about what's going on.
Okay.
Try to normalize emotions that we usually hide. You need to let the staff know, look, we are all going through this.
Yeah.
We're all going through this. If you feel like crying, please, you're not alone. These are challenging times. Yeah, and just have to make the staff feel that they are supported.
Of course.
Yeah.
That's important.
Yeah.
Absolutely. How do you personally stay grounded and resilient in a field, that deals daily with life and death?
I mean, to me, I stay grounded because I look at what I do as a privilege that many people don't have. It means a lot to be a physician. To me, being a physician is a vocation. Purpose is what gets you there, and my purpose is to make sure that I'm taking care of patients in any way that I can. And with that, I'm fine. It's just a privilege. I'm just glad to be able to do it, and not too many people have that privilege to take care of other human beings.
Absolutely. You have to love what you do when you do something like that. So given your journey from Cameroon to New York, from seminary student to critical care leader, what advice do you have for young physicians or anyone striving to serve their communities through medicine?
The first thing I tell them is it's a wonderful thing to become a physician. I tell them as well, you should have only one purpose, and one purpose, and that purpose is to serve. And the only way you serve is to care. Treat every human being like you like to be treated. If you do that, you're going to be a wonderful physician.
That's great advice. Very, very true. Wonderful. Well, I would like to thank you so much for being my guest today and educating our audience about what goes on in the ICU and your journey from Cameroon to New York and what that was like. Your insights, and your experience are truly valuable coming from the front lines of critical care, and it's been a privilege not only to hear, the technical side, but the human side behind the decisions and the people that you serve.
Thank you very much, Meredith. I really do appreciate this opportunity.
Absolutely. So to our listeners, I would like to thank you for tuning in. We hope that this episode gives you a deeper appreciation for what happens behind hospital doors and how leadership, compassion, and training all converge in the ICU. And if you'd like to learn more about Dr. Nfonoyim's work or the services of Richmond University Medical Center, you can visit rumcsi.org. Until next time, RUMC Connections, I'm your host, Meredith Gaskins. Stay curious, stay informed, and stay empowered.